Welcome to the Step 1 primer video on systolic heart murmurs, which, like the video on diastolic murmurs, contains sample heart sounds to help you get ready for the audio-visual questions on Step 1. We hope you enjoy it.
It's time for the 3-question warm-up for Cardiovascular 9. Let's get going. Outline the pathway of converting phenylalanine to epinephrine. So the first step is going from phenylalanine to tyrosine. The enzyme phenylalanine hydroxylase actually adds a hydroxyl group here. Be sure to know that enzyme. Next, going from tyrosine to dopa, the enzyme tyrosine hydroxylase adds another hydroxyl group. Next, you go from dopa to dopamine, and the enzyme here is dopa decarboxylase. This requires B6, and this is the enzyme inhibited by carbidopa. Next, you go from dopamine to norepinephrine, and then the last step is norepinephrine going to epinephrine. Next question. Name 8 different indirect cholinergic agonists and state the use for each. So these drugs inhibit your acetylcholinesterase enzyme, thereby allowing acetylcholine to stick around longer, which is why they're sometimes called indirect agonists of acetylcholine. So these include first neostigmine. This is sort of the prototype indirect agonist, and it's used for neurogenic ileus. It's a post-op reversal agent for neuromuscular junction blockade as well. It's sometimes used for myasthenia gravis as well. Pyridostigmine gets rid of myasthenia gravis as well. Edrophonium is a drug used to actually diagnose myasthenia gravis. It's not used for treatment. Physostigmine is going to fix atropine overdose, so you can use it for people who've taken too much atropine. Ecothiopate is used for glaucoma. And then there's your Alzheimer's drugs. That's going to include donepezil, galantamine, and rivastigmine. Next question. Outline the flow of fetal circulation. So the umbilical vein carries oxygenated blood from the placenta, and it first goes to the liver. In the liver, you have mixing of oxygenated blood from the umbilical vein with some of the deoxygenated blood from the lower extremities, which takes place at the ductus venosus and the inferior vena cava. In the right atrium, the blood can take one of 2 pathways. First, it can either pass through the foramen ovale and go directly to the left atrium, or it can go through the right ventricle into the pulmonary artery. If you go from the right ventricle to the pulmonary artery, there are 2 more pathways that the blood can go. The blood can either go to the lungs, or it can go through the ductus arteriosus, which is a fetal connection between the pulmonary trunk and the aorta. But the blood that went through the pulmonary artery to the lungs will go to the left atrium and meet up with the blood that came from the right atrium directly through the foramen ovale. So there are 2 different pathways to the left atrium. Either way, the blood then goes to the left ventricle and through the aorta. The blood going through the aorta is going to meet up with that blood that came through the ductus arteriosus. And then all of that will go from the aorta out into the rest of the systemic circulation. And part of that systemic circulation goes through the umbilical arteries back to the placenta to drop off CO2 and pick up more oxygen and nutrients. All right, that's it for the 3-question warm-up. Let's get to that lecture now.
In this video, we're going to wrap up heart murmurs by talking about the major systolic murmurs: aortic stenosis, mitral regurgitation, mitral valve prolapse, tricuspid prolapse, and VSD. And I'm going to assume you've already watched the previous video where we introduced some basic concepts related to diagnosing heart murmurs. And again, heart murmurs are a 5-star topic, so make sure you know this stuff. Let's start with aortic stenosis. Now, aortic stenosis is definitely my favorite valvular lesion, which sounds pretty dorky. But anyway, before we look at the phonocardiogram, I want you to try to reason out something. You know that aortic stenosis is a systolic murmur, so you're going to hear it between S1 and S2. But do you expect the murmur to begin right with S1, or will there be a little gap? Well, there's a little gap between S1 and the onset of the murmur during that isovolumetric contraction period. So during isovolumetric contraction, the mitral and tricuspid valves have closed, and that causes S1, and the ventricles are contracting, but the pressure isn't high enough to open up the aortic and pulmonic valves yet. So even if there is some aortic stenosis, right after S1, the valve should be closed and no blood is flowing across it. So there will be no murmur at the very beginning of systole. And then when that pressure gets high enough that it exceeds the pressure in the aorta, it forces open the aortic valve. Now when the valve opens, you have an ejection click due to those valve leaflets coming to an abrupt stop. The leaflets are usually scarred and calcified. That's why they aren't opening fully. That's why you have stenosis. So those calcified leaflets come to an abrupt stop, and it makes an abnormal sound, which is called an ejection click. Definitely know that. So you hear S1, then there's an ejection click, and then the murmur starts. Now the murmur is sometimes described as a crescendo, decrescendo murmur. Those are musical terms. Crescendo means it gets louder, and then decrescendo means it gets softer. So you hear the murmur start soft after that ejection click, then it peaks in intensity, then it decrescendos or gets softer, and it ends at S2 when the valve closes. Or sometimes you'll hear it described as a diamond-shaped murmur. So listen. That ejection click is hard to hear, but as long as you can tell that this is a systolic murmur in the aortic position, the right second interspace, you have a strong suspicion that you're listening to aortic stenosis. There are also a few important clinical clues that can help you. Not only is the murmur heard at the aortic position, but it's also going to radiate to the carotids. Now, as blood goes from the ventricle through the aortic valve and up into the carotids, it's still going to have all that turbulent flow all the way up into the neck. So if you put the stethoscope on the carotids, you can hear that systolic murmur. And it sounds a lot like a carotid bruit. You can also feel weak, delayed peripheral pulses, which is kind of what you'd expect. That narrowed stenotic aortic valve is kind of blocking the blood from going into the aorta, and it reduces the force of each beat. So you're not going to perfuse very well because you're not maximizing the blood that can flow through the aortic valve with each contraction. So as a result of this, not only do you feel weak pulses, but the patient might have syncope. So if normally you're able to push a certain volume of blood through, now with stenosis, you can't push as much blood through. You're not going to get as much perfusion, not only to your pulses in your extremities, but also to your brain. So if you have an elderly patient that comes into the emergency room with syncope, then you need to think about the possibility of aortic stenosis. Now, besides syncope, two other symptoms you should think about with aortic stenosis are chest pain, or angina, and also shortness of breath, or dyspnea. So you should definitely know those three: syncope, angina, or dyspnea. You don't have to have all three. If you have any one of those in the presence of aortic stenosis, it's very dangerous, and it's time to replace that valve. So what causes aortic stenosis? Well, there are 5 causes of aortic stenosis that I want you to know, and this is in your study guide number 4. The most common is a bicuspid aortic valve. So instead of having a 3-leaflet aortic valve, the patient just has a 2-leaflet valve. We saw that could be a potential cause of aortic regurgitation as well. So bicuspid aortic valve is a congenital defect, but it generally doesn't start causing problems until around age 40. So most people with bicuspid aortic valve don't know they have the problem until after age 40, when that abnormal valve starts to become calcified, kind of similar to the calcification you would get in your vessels due to atherosclerosis, only this is on the valve leaflets. So the patient's born with a bicuspid aortic valve, and then as they age, that valve becomes calcified. They start having progressive stenosis of the valve, and they start to have syncopal episodes or chest pain or other evidence of aortic stenosis. So that's definitely something to be aware of. A second cause of aortic stenosis is what's called senile calcification or degenerative calcification. So here you have a normal 3-leaflet aortic valve, and then it becomes calcified. This usually becomes apparent after age 60. So it takes longer to become problematic, not because it becomes calcified later, but because that normal valve can naturally open wider than an abnormal bicuspid valve can. So a bicuspid valve is already a little narrowed, and then that senile calcification just becomes symptomatic earlier, about 20 years sooner than it would if the patient had a normal valve. So if you have a patient over the age of 60 that develops aortic stenosis, think about senile calcification or degenerative calcification. A third cause of aortic stenosis is chronic rheumatic heart disease. So rheumatic heart disease can cause lots of different murmurs, especially mitral valve lesions, but rheumatic fever can damage the aortic valve as well and can lead to aortic stenosis. Another cause of aortic stenosis is that you can have a congenital unicuspid aortic valve, so it just has one leaflet, much less common than any of these other causes we've just mentioned. And then a fifth cause would be syphilis, because again, tertiary syphilis can affect the aortic root and they affect the aortic valve, just like we saw with aortic regurgitation. So again, number 4 in your study guide, those 5 most common causes of aortic stenosis are a congenital bicuspid valve, senile or degenerative calcification, chronic rheumatic valvular disease, and again, those are the big 3. And then number 4 would be a unicuspid valve, number 5 would be syphilis, and that's very rare. Next, let's talk about mitral regurgitation, which is another common systolic murmur. Unlike aortic stenosis, here you see that the murmur begins immediately following S1. Again, what causes the S1 heart sound? Closure of the mitral valve and tricuspid valve. So during systole, the mitral valve should be closed. There shouldn't be any blood flow across it. But if the valve doesn't close completely, as the left ventricle contracts and pressure rises, blood is forced back across the mitral valve into the left atrium. So blood regurgitates back across the valve. So this murmur starts right after S1 during that isovolumetric contraction period, and it continues all the way to S2. So we say that mitral regurg is a holosystolic murmur. It occurs throughout systole. It's also commonly described as a high-pitched blowing murmur, but that's not nearly as helpful for your exam as the fact that it's holosystolic. And where are you going to hear this murmur best? Where's the mitral area? The apex, the fifth intercostal space in the mid-clavicular line. And mitral regurg murmurs can radiate to the left axilla. So clinically, if you put your stethoscope in the patient's axilla, you might hear the murmur up there too. And remember, we also said that mitral murmurs are better heard when you put the patient in the left lateral decubitus position, lying down on their left side. Now, mitral regurg is enhanced by maneuvers that increase total peripheral resistance, or afterload. So hand grip will do this, and so will squatting. So hand grip makes it harder for the left ventricle to eject blood because there's higher afterload. So if there's more blood in the left ventricle and then more pressure, more blood is going to regurgitate back across the mitral valve, and that regurg murmur will be louder. So what are the causes of mitral regurgitation? So rheumatic heart disease is by far the most common cause. The valve that's affected most frequently by rheumatic fever is mitral valve. Endocarditis can also damage the valve and cause mitral regurgitation. Mitral regurgitation can be due to ischemic heart disease or left ventricular dilation. So if the heart dilates, you can imagine how that might cause some separation between the valve leaflets. They're just being pulled apart by that dilated heart so that they're not closing properly, and then blood can leak back through. And then mitral regurgitation can also be associated with mitral valve prolapse. Now, I want you to recognize that those two can occur together, but they don't have to. You can have prolapse without regurgitation, or you can have mitral regurgitation without mitral valve prolapse. So don't link them together in your mind. Next up is mitral valve prolapse. It's a very, very common murmur. And even though it's a very common murmur, it isn't usually clinically problematic unless there's mitral regurgitation associated with it. So what is mitral valve prolapse anyway? Think about mitral prolapse as being a large, floppy mitral valve leaflet. So almost like there's redundant tissue so that the valve leaflets billow out like a parachute. So during systole, the mitral valve is closed, but it's prolapsing back up into the left atrium, expanding, 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 then pop! The chordae tendineae reach their endpoint, and you have this mid-systolic click. So here you see the mid-systolic click, and then you might hear a systolic crescendo murmur after the click that increases in intensity as you approach S2. Something else that may be worth knowing is that when you have the patient Valsalva, that makes the mid-systolic click happen earlier, and it makes the murmur start slightly earlier as well. But like most murmurs, the murmur gets slightly softer with Valsalva. So the murmur starts earlier, but it's softer. Let's also briefly mention tricuspid regurgitation. Now, the tricuspid valve is the right-sided equivalent of the mitral valve, right? So the murmur sounds the same as mitral regurg. It's a holosystolic murmur, but it's going to be loudest in the tricuspid area. So it's very important to move that stethoscope around on the simulated patient on your test. The other important distinction is that the murmur of tricuspid regurg is louder with inspiration because of that increased right atrial return. Remember, if you hear a murmur that gets louder with inspiration, it's more likely to be a right-sided murmur like a tricuspid murmur. If your murmur gets louder with expiration, it's more likely to be a left-sided murmur like a mitral murmur. So, what causes tricuspid regurgitation? Again, rheumatic fever and endocarditis. And then what type of patient is most likely to have tricuspid endocarditis? I want you to think about IV drug users. I mean, they're shooting bacteria into the veins. That's going to go to the right side of the heart first. So you're going to see tricuspid endocarditis and then subsequent valvular damage and tricuspid regurg. We're going to talk about that again when we get to endocarditis. Let's talk about one more systolic murmur, which is caused by a VSD, a ventricular septal defect. And this is another example of a non-valvular heart murmur. So this is caused by a hole in the interventricular septum, so that blood can pass from one side to the other. So what does this murmur sound like? You can see that it sounds a lot like the mitral or tricuspid regurg murmurs. It's a holosystolic murmur, and it's best heard along the mid to lower sternal border on the left, kind of in the tricuspid area. So by auscultation alone, it's going to be very, very difficult to distinguish between tricuspid regurg and a VSD. This is where the clinical scenario is important. If they give you a newborn with this murmur, go with VSD. If they give you an IV drug user with this murmur, go with tricuspid regurg due to IV drug use causing endocarditis. So that's it for the heart murmurs. Again, very, very high yield stuff. Now it's time for the end of session quiz, so I want you to take a look at those questions. Now, this big table is actually a good review of all the murmurs we've been discussing, both in this video and the last video. So work through those, and then we'll go over them together. All right, first question. Which heart murmur is associated with weak pulses? It's aortic stenosis. And sometimes this finding is called pulsus parvus et tardus, which is Latin for weak and delayed pulses. And then here's our enormous table. What pathology is associated with each of the following murmurs? Crescendo-decrescendo systolic murmur, heard best in the second to third right interspace close to the sternum, is going to be aortic stenosis. And even if they didn't say crescendo-decrescendo, but just a systolic murmur in the aortic region, it's probably enough to give you the diagnosis of aortic stenosis. The next one is early diastolic decrescendo murmur, heard best along the left sternal border with blood pressure of 160/55. That's most likely aortic regurgitation with that wide pulse pressure. Very important clue. Then a late diastolic decrescendo murmur, heard best along the lower left side of the sternum, would be tricuspid stenosis. A holosystolic murmur, heard best at the apex and often radiates to the left axilla, is mitral regurgitation. A late systolic murmur, usually preceded by a mid-systolic click, is mitral valve prolapse. Crescendo-decrescendo systolic murmur, heard best at the second or third left interspace close to the sternum, would be pulmonic stenosis. So it's similar to aortic stenosis, but the location is different. A holosystolic murmur, best heard along the left lower sternal border, could be either tricuspid regurg or a VSD. Remember, we said they're very difficult to distinguish. You need the clinical setting to make a more accurate diagnosis. A rumbling late diastolic murmur with an opening snap, heard loudest in the fifth interspace in the mid-axillary line, is mitral stenosis. And a continuous machine-like murmur occurring both in systole and diastole is a patent ductus arteriosus. All right, that's it for Cardiovascular 9. I'll see you next time.
Hey girl! Whoa, I seriously need to know when you're going to let me borrow that top! Anyway, so during rounds today, I was presenting this patient with syncope from aortic stenosis, and Dr. Wilkerson was all like, describe his murmur. So I was like, it was a harsh, high-pitched grade 2/6 crescendo-decrescendo systolic ejection murmur radiating to the carotids. And he was all like, did he have strong pulses? You know, trying to trick me. And I was like, cha, as if. The pulses were weak and delayed, you know, classic pulsus parvus et tardus, dude. My physical exam skills are like seriously legit. So we sent his butt into surgery. The patient, not Dr. Wilkerson. Okay, so when can I borrow that top? Seriously.